Good morning. My name is Claire Clark and I am from Dynham. We are supporting Highlands and Islands Enterprise to deliver this event today. It's great to have you all with us for this Business to Healthcare webinar. A very warm welcome to you all. Before I pass you over to Andrea McCall from High, I'd just like to spend a minute explaining how we will run today's webinar. As an audience member, you are automatically muted, but we have a couple of ways for you to get actively involved. You can use your question box at any point throughout the webinar and we will pick up as many as we can during the Q&A. You'll also see an icon called the raised hand icon, and during question time, if you've got a mic and you want us to take you off mute so you can connect directly with our speakers, then just click on that icon and we'll get you connected. And finally, we always want to promote knowledge sharing and collaboration, so we do record every session. We will, of course, share the recording after the event so you can watch again or share with anyone else you think might be interested. That's all from me now. I'll pass you over to Andrea, who will introduce today's speakers. Andrea, over to you.
Thanks, Claire. Yeah, thanks and welcome everybody to our webinar today. I just wanted to give a brief introduction from my point of view. So I'm Andrea McCall. I work in the Life Sciences team at Highlands and Islands Enterprise in Inverness. And I just want to tell you a little bit more about the Business to Healthcare program, which this webinar is part of. So the program is designed to support companies who would like to develop and sell products and services into the healthcare sector. And the program is actually funded by the Inverness and Highland City Region deal and European funding. So we have support available for the businesses, and it's a very tailored support package so that everyone gets the support they need to move their product and service further along the commercialization journey. So without further ado, I just want to let you know that today's panel of speakers is actually a really big panel. So we're excited to have so many companies joining us today. So we have two people from Joint Academy, Hakan and Leif. We have Stanley from Optometry Evolution, Session from Apos, and also Helen Robertson from the National Treatment Centre Highland. And you can see all these companies and people all fall within our topic, which is eyes and bones, innovations in ophthalmology and orthopaedics. So it is really eyes and bones we're talking about today from different points of view. But we also are joined today by one of the business advisors that we have on the Business to Healthcare program, Adrian Smith, who will actually host the session for us today. So without further ado, I will actually hand over to Adrian to take us through the session today.
Many thanks, Andrea, and let me add my welcome to everybody too. I think it's really exciting that we're holding this event today, which is driven really by the fact, as you'll hear right at the end from Helen, about the new National Treatment Centre in the Highlands, focusing on ophthalmology and orthopaedics. So it's great that we've been able to assemble a group of the B2HC involved companies whose solutions feed into the agenda that the National Treatment Centre is all about. And I'm really looking forward to hearing from Helen at the end of the session about how the centre's going and about its hopefully opening towards the end of the year, but we'll hear from her. I'm not going to tell you a lot about each of the companies, but it's a good mix. We've got a couple focus on the orthopaedics end of the spectrum, and then a couple looking at ophthalmology related solutions. But we'll let each of them introduce themselves and what they're up to. So we're going to start with 10 minutes from Sachin Gohil, who's the Senior Vice President at Apos Health. And Apos have an exciting route to tackling knee and lower back and hip pain by gait improvement. But you'll hear a lot more about that from Sachin. So over to you, Sachin.
Hi, everybody. I'm Sachin Gohil. I'm Chief Commercial Officer at Apos Health. Delighted to be here to talk to you about Apos and our innovation. So Apos is a treatment for chronic knee pain as a result of knee osteoarthritis. We treat patients with moderate to severe osteoarthritis, and it's in those patients for whom non-surgical treatments have failed. And we can actually help prioritize surgical patients based on clinical need. And we do that by offering an alternative for patients that simply have nowhere to go. I'm going to spend a couple of moments just talking very briefly about the problem, but I think everybody's aware of some of the burden that MSK conditions have on the NHS. So it's a huge spend of UK NHS expenditure. 8.5 million people suffer from osteoarthritis in the UK, of which 5.2 million suffer from knee OA. And of the 120 or so thousand knee replacements that are performed each year in the NHS, over 90% of them are due to knee OA. And we're all aware of the elective backlog issue that we have at the moment. So there are 2-year, 3-year, 4-year waiting lists, depending on where you look, for patients to be able to actually access surgical treatment. And overwhelmingly, people just want to get back to their normal lives and be more active and do the things that they love. So some of the challenges that we have with the knee OA pathway at the moment is that there is a wide gap between non-invasive and invasive treatments, both from a therapeutic point of view and also from an economic efficiency point of view. We have treatments that are recommended by NICE in terms of education, physiotherapy and opiates, but up to a point they work and then patients tend to move down a more invasive route. Surgery isn't without its risks. And really where Apos comes in is that we're able to offer an alternative in that big gap in between non-invasive and invasive. So Apos is effectively a all-in-one CE and FDA cleared device that gets patients back to living their lives by helping them reduce their pain, improve their mobility, and they do so just by wearing the device for an hour a day. How it works is that there are 2 key contributing factors for knee OA. So we have a misaligned pressure, a center of pressure within the knee joint that causes increased pain. And as a result of that pain, we have this bracing of the muscles around the knee that is a protective posture from the body. But what that does do is it induces this vicious cycle of pain. So we have this issue with knee OA patients where exercise is one of the best treatments for them. However, they just can't do that exercise because they have this pain within their knee. So what Apos does, and it's not new treatment, it's taking the principles of biomechanical alteration of gait and then also looking at the principles of a wobble board, but we're combining that all into one device. So what we have in Apos is at the bottom of the device, we have these 2 rails that are positioned at the front and the back of the foot. And to these rails, we can affix these pods. Now, these pods allow us to manipulate the center of pressure within the knee joint and actually alter the way in which the patient walks so that we can start to reduce the center of pressure in that knee and reduce their pain. That's not new. That's what a tried and trusted biomechanical alteration of gait. But what we can do at the same time of that alteration of their gait is that the convexity on these pods allow for this slight wobble effect, which induces muscle proprioception around the knee joint, so that it starts to create a motor learning pattern for the patient so that they feel the benefit even when they're not wearing the device. So it's not magic, but it's the same principles as a wobble board and an altering gait, but we combine it in one device and there isn't another device like it in the market. In terms of a patient journey, it's pretty simple. We have an initial evaluation where the patient will have a computerized gait test, and they'll also have a visual gait test with a physiotherapist. The device is then calibrated specifically for the patient based on their symptoms and how they're responding to the treatment. Patients are then asked to wear the device for an hour a day. And then every couple of months, they'll have a recalibration visit where we might need to adjust the calibration, or if they're progressing really well, we'll leave it as it is and see how they go. And through that, we're able to start to get patients moving again. Typically, after a couple of months of daily wear, patients start to feel the benefit in their normal footwear. And one of the reasons why we get really good adherence and compliance rates and great outcomes is because it is just putting a pair of shoes on at home, just doing your normal chores, so making a cup of tea or making a meal. Where we see Apos fitting in with current NICE guidance is it sits into the adjunct bucket. So we're aware that everybody needs that core management of education, exercise, weight loss, That's so important to making sure that we can maintain and help modify the symptoms of knee OA. Sometimes that's not enough, so that's when pharmacological treatments come in, but then also other devices and supports. And really what we're positioning Apos as is that at the time a patient is being considered for a brace, that's when we would suggest Apos is considered. We know that compliance is better than the brace, and we know that it actually has much better outcomes as well. In terms of clinical evidence, because I think this is really important, is that we have CE and FDA clearance as a medical device for treatment of knee osteoarthritis. We also have indications for hip and lower back pain as well, because it's all linked to that manipulation of gait. But our clearance is for the knee OA. And we have extensive peer-reviewed clinical studies looking at Apos in terms of, is it safe, which it is, it reduces pain levels, and it also avoids surgery and provides long-term outcomes for patients as well. We have randomized controlled trials, double-blinded in JAMA, and it shows that the principles and the clinical impact of Apos is absolutely there. So in terms of trial data, that's there, but also we have real-world NHS outcomes as well. So within a population in England, in CCG in England and Mid-Essex, we're able to take a cohort of around 400 patients and treat them with Apos. These are patients that would have gone on for a surgical opinion through a shared decision hub. And at 2 years, we were able to demonstrate that 84% of that cohort are able to avoid surgery. So we have long-term outcomes with our treatment, and we know that it works. And really here, what we're saying with Apos is that it provides a really useful alternative to surgery, especially when you've got patients that are on a waiting list that aren't waiting well at the moment, that are continuing to deteriorate. And it also provides breathing space for the system in terms of recovery as well. Patients love it. 98% of our patients will recommend Apos to friends and family. We know that it works really well, and actually the patients that we do have, we have a growing body of patient advocates. We've treated over 10,000 patients in the UK and over 110,000 patients worldwide, and we have a really good community of patients that love to talk about Apos because it has actually had an opportunity, a transformative effect on their lives and allowed them to get back to their normal activities. So in summary, and I hope I'm all right for time. So Apos is it's a device. It's a medical device that's based on biomechanics and motor learning. And really, where we're positioning Apos is that it offers an alternative for those patients that are high risk, unsuitable for surgery, or where it's beneficial to avoid or delay knee surgery. We know it supports system recovery by increasing resource capacity. And we've also been reviewed by NICE as well. So currently in February this year, we had a MedTech innovation briefing published by NICE, and we're currently going through a MedTech evaluation program. Apologies for this transition on this slide. And we're also available via the NHS supply chain as well in England. So in terms of implementation within the NHS pathway, we believe we've got that working really well, and yeah, and that's what we are. We're Apos. So happy to take any questions now or later when we have question time.
Many thanks, Sachin. You're absolutely spot on time. So let's hope others that follow you do the same. I've certainly got some questions, but I'm going to do as was suggested by Claire at the start and save them till the end, because we've got a nice slot available for questions at the end. But thanks very much. That was very clear, and I look forward to talking to you a little bit later. So our next session, sticking with the orthopaedic side of eyes and bones, is from Joint Academy, who are also in the osteoarthritis, but have a digital first-line treatment approach. And I'm going to hand over to Leif and Hakan to talk us through Joint Academy. Over to you.
Continue on the orthopedic part here and talk further on osteoarthritis and also chronic joint pain. Next, please. We have already got a nice presentation. So I'm Leif Dahlberg, I'm a co-founder and senior professor in orthopedics in Lund. And Håkan, you may say a couple of words.
Yeah, I have a background in physical therapy. I'm a VP of clinical strategy at Joint Academy and also research at Lund University.
Next, please. So very short about our history. We heard about the guidelines in previous talk that emerged early in the 2000s with from clinical research, and also new guidelines were written, and it was all supporting that OA should not be considered a wear and tear disease, but it actually supported that exercise was the first line treatment. So in Sweden, we developed a structured protocol for face-to-face treatment, better management of patients with osteoarthritis, that since then have treated some 200,000 patients. We realized that the implementation of the first-line treatment was to a large extent lacking, so we made a digital launch that was joined Academy in 2018. And today we have treated worldwide more than 100,000 patients, and on the platform we have 500 plus physiotherapists taking care of the patients. Next. So this is, as you have understood, a digital solution, and there is an interface for the patient which gives the patient daily exercises and education. That is, we also have a personal support from the unique physiotherapist behind the patient. There are videos on the exercises. We can monitor the changes during the treatment, and there is also peer group sessions for the patient in the app. Next, please. There is also an interface for the physiotherapist with a dashboard, and the physiotherapist can monitor what's going on with the patient, which patient is active and needs or needing further support, and so on. It's a chat possibilities, and of course all the monitored results are available for the physiotherapist. Next, please. So we heard a little bit about osteoarthritis. I will put a couple of more perspectives of the disease. Today it's clear that the diagnosis is made by symptoms. It's a clinical diagnosis. However, it's been still people tend to diagnose and treat structure rather than symptoms. The problem with this is that the symptoms and structure are not very much in agreement, which means that patients may have a lot of pain, but very little structural changes. Also, the structural changes emerge much later than the symptoms, which means that a lot of patients then lack proper treatment. Next, please. So we heard that osteoarthritis is very prevalent and it is increasing over time. Next. So the first line treatment is education, exercise, and weight control when needed at all time points and to everyone. And then there are some additive treatments which could be painkillers, aids, and then for a few of the patients, they will need surgery in the end stage of the disease. Next, please. So the interesting thing here is that the first-line treatment is actually activating the patients, because research have shown, as you can see, half of the 40 million people with OA in the US are physically inactive. And as a result, you can also see all the morbidity that is coming with this inactivity. Next, please. So it's all about getting a diagnosis correctly and then the right treatment at the right time point. And much of that is actually to balance the risk with the treatment, the cost of the treatment, and the outcome of treatments. Next, please. And when it comes to osteoarthritis, it's very much a question on when surgery is needed, should be done, and is done by evidence. You may know that you should avoid arthroscopies in knee pain in the middle age, still done to a large extent. And joint replacement should only be used when first-line treatment fails. And that is one of the bare reasons for that is also the risk of being operated on. Next, please. Painkillers can also be very dangerous, as been shown in this study, that almost half of the cardiovascular disease risk in patients with osteoarthritis is due to NSAIDs. So an NSAID now and then is fine, but most of the patients with OA uses them regularly. Next, please. So we also have the question of cost effectiveness and evidence, and it's been shown that a lot of the healthcare spending actually consists of low-value care that offers no benefit but may harm the patient. So it is really important that we are using treatments that we know are evidence-based and scientifically proven, and not spend money on other treatments. Next, please.
Yep, I'll take over from there. Thank you, Leif. I'd like to say a few words about the research we've performed in the company and some of our outcomes. So currently we treat 6 different types of disorders: hip and knee OA, low back pain, shoulder pain, hand OA, and neck pain. And for each of these programs, there are health questionnaires distributed to the patients on a regular basis. And these questionnaires contain outcomes such as pain, physical function, quality of life, demographic factors, and so on. And using these outcomes, we've so far published more than 10 peer-reviewed published studies in journals such as JAMA Open, PLOS ONE, BMJ Open, and Osteoarthritis and Cartilage. And I'd like to focus on 3 specific studies which we think are extra interesting. So first off, there's the RCT, the randomized controlled trial, which was performed by Nottingham University, where 105 patients were randomized and analyzed, and they were randomized to 2 groups, either usual care, which is guideline-based self-management by general practitioners and physical therapists, or 6 weeks of treatment in Joint Academy. And the results show that Joint Academy was superior to care as usual in terms of decreasing pain to 41% compared to regular care 6%. Function was increased to 48% compared to usual care 13%. There was also a greater decrease in stiffness in the Joint Academy group. Secondly, we have our observational long-term study, and here we looked into patients that had participated for 6 months and up to 12 months. And the results show that 75% of all activities, and in this case activities is exercise, educational sessions, health questionnaires, quizzes, etc. 75% of these activities were completed during the 6 months, so there was a high adherence. 42% of patients reported that they stopped taking medication. There was in general a 50% pain decrease over 6 months, and the following 6 months up to 12 months, the pain had stabilized and continued in this low trajectory. 52% of those reporting that they wanted surgery at baseline no longer needed surgery after 6 months. And thirdly, I'd like to mention a cost analysis study that was performed by an external health economist. And in this case,
1 minute if possible, Håkan.
Okay, sure. The cost analysis compared costs for visits, administration, etc., and showed that Joint Academy cost 25% of a structured face-to-face program called the VOA program that's currently administered nationally in Sweden. And then there's also an Islands and Highlands pilot project by the University of Islands and Highlands, where they recruit patients on waiting lists for knee and hip replacement surgery that will test Joint Academy to see if they improve and if they're engaged and happy with the digital treatment while waiting for surgery. And I'll end off with some patient feedback. In general, our patients are very happy with the treatment and feel that it really helps them in their day-to-day living. Thank you.
Fabulous. Thank you both very much indeed. Very, very exciting and interesting. Not an expert, but it sounded to me like Apos and yourselves are complementary. So if you're not already talking to each other, maybe you should. But we'll come to that in the questions perhaps a little bit later. So that concludes the first half of the session, focusing on the orthopaedic side of our eyes and bones. We're now going to swap over to the eyes side. And to begin with, we've got a short video from one of the companies in the B2HC program, Retina Risk, who are a leading provider of an app and API for diabetic retinopathy. So Claire, if we're able to show that video now, that would be wonderful.
My name is Einar Stefánsson. I'm an ophthalmologist and I have founded a few R&D companies. I founded Retina Risk based on my research and clinical experience with the aim to improve the execution and economics of healthcare with individual risk profiling and personalized care. The basic goal is to ensure that the patient receives the appropriate treatment at the optimal time point and frequency. Our initial focus is diabetic eye disease. We have built a clinically validated algorithm and software platform that accurately calculates risk of sight-threatening diabetic eye disease based on the patient's clinical risk factors, such as blood glucose and duration of diabetes. I believe algorithms and artificial intelligence for personalized approach is the future of healthcare. Risk calculation can be applied to other aspects of diabetes and other chronic diseases. With this personalized risk-based approach, we can reduce healthcare costs and personalize healthcare.
Thank you very much indeed. So Retina Risk have been in the B2HC program almost from the outset, and we're delighted that they're still excited about the opportunities in the Highlands and in Scotland more broadly. And now turning to something that has really developed in the Highlands very successfully, we're going to hand over to Stanley, who's going to talk about Optometry Evolution, who've been supporting and promoting high quality eye care through training and education. Hope I've got that right, Stanley, but I'll leave you to explain much more about it. Over to you, Stanley.
Thank you very much. And thanks again for the invitation to speak on the webinar this morning. So just to introduce myself, I'm Stanley Keys. I'm a hospital-based optometrist in Rigmore Hospital, Inverness. I spend about 4 days a week in hospital in the clinical setting, and 1 day a week working on this sort of side project, if you like, Optometry Evolution, which is really an educational resource for optometrists, but also for ophthalmic nurses and the wider eye care community. So just a little bit of my background. So I qualified in 2003 and I've been working in the hospital setting since then. My main clinical interests are in glaucoma, where I do a lot of look after a lot of the glaucoma patients here in the Highlands, and also with acute eye care, the sort of eye casualty conditions, the urgent and emergency conditions. And that's an area where I think is really quite interesting, and a lot of the emphasis of what I do through Optometry Evolution is really placed upon that. I've also always had an interest in education, whether it's training fellow optometrists or in the GP community, in different formats. So a lot of that work I really tried to put together through the development of the Optometry Evolution website in 2018. So I enlisted the help of a good web designer locally who helped with the branding and putting this together. And really, in the initial phase, it was kind of a two-pronged approach. So I was using the website as a platform to put forward just free sort of clinical articles for optometrists or for the front of house staff, particularly in the area of sort of emergency and acute eye care. And then I was using this as and still do, as a platform for tutorials and different sort of online sort of educational offerings to the optometry community and to the front of house staff. But one of the main areas that I kind of identified that I didn't think there was any educational activity was really for the front of house staff, the receptionists, the assistants and so on within the practice. Because invariably, if a patient phones up with maybe flashing lights and floaters in their vision, or a painful red eye, or maybe an injury, it's always going to be a front of house staff member that they will speak to first, rather than the clinical member of the team. So I thought really there's a piece of work to do there around awareness and effective triaging from the front of house staff point of view. So I developed some resources, physical resources to help with that, which I will show you in a moment, and also some online courses that would sort of supplement that and bolster that piece of education. And I also do just some CPD tutorials for optometrists on various clinical aspects. So this was the first kind of physical resource that I developed. So it was a kind of a resource pack. And if you look on the left, it comprises of 3 key elements. So this is really for your front of house staff member. So there's some cards there which are really just to increase awareness of ocular emergencies. So what are the different categories of emergencies? What are the red flags? What are the things that should kind of ring the alarm bell for that staff member? And in doing so, then it should prompt them to fill out one of these triage notepads, which you see in a bit more detail on the right-hand side. And that just is designed to gather hopefully quite concise information regarding just what's been happening in the patient, so that they can take that to the optometrist, so to the clinical member of the team, and ask them, what's the best course of action for this patient? And in doing so, hopefully minimizing any delays for treatment. So you don't want somebody who has an impending detachment of the retina, or maybe, who in fact maybe has a retinal detachment with the associated symptoms. You don't want their examination and referral into the hospital to be delayed. So it's really all aimed at sort of minimizing these kind of scenarios. And the final part of this resource pack was this little training booklet. So, little in-house discussion scenarios can be carried out every few months, just to keep this sort of alive, if you like, or fresh within the practice team. So, as I say, that was the first kind of thing I developed, and during COVID, took this onto a sort of an online training. So, do an evening tutorial, and people can sign up, get their practice team onto the course, and they get the pack and so on as part of that arrangement. So the next phase of what I've been doing, really, again, prompted by our experience of COVID, and now thinking within the secondary care setting, so within the hospital setting, I was much more involved in delivering sort of casualty clinics and also supporting our ophthalmic nurses with triaging. As you can imagine, our triaging had to be really quite efficient and quite sort of tight and accurate during the initial phases of lockdown. And the feedback was that our ophthalmic nurses were very positive with the support and input that they received from myself and other members of the optometry team. And whenever I kind of chatted to them about it, it sounded as though really it's not an area that they ever really get any formal training in. It's just something that's learnt just sort of passively, if you like, on the job. So and again, I looked around, there's no real courses that sort of tackle this area, just to make triaging a little bit more succinct and just to, I suppose, build the confidence of the ophthalmic nurse to make the right decisions, to gather the right information from the point of referral. So that kind of prompted me to develop an educational piece around this, really targeted at ophthalmic nurses. So I started to write this booklet. So it's a 32-page guide on ocular triage, really covering things like how to take a clear history, what are the key principles of effective triage, what makes a good triage system, good communication, and then it offers a fairly broad review of the main sort of urgent eye conditions, the red flag signs and symptoms. What are the questions we want our nurses really to be asking whoever's referring this patient? So again, I sort of developed this into an online course. So it's a kind of a two-part course because there's quite a lot of material. So 2 evening courses, so it's very accessible for you know, the nurses. So a lot of them have very busy working lives, they've got very busy family lives. So trying to make it as accessible as possible. So typically their trust will pay, you know, the course fee. That includes the 2 tutorials, a copy of the guide, and CPD points for that. So it was really in spring of 2021 when I was accepted onto the Business to Healthcare program, and that was incredibly helpful with this project. So it helped me, I guess, put quite a lot of structure to how, you know, I was developing the course. Things like what was the appropriate length of the course, maybe how to price it, how to market it, and, you know, just getting some extra contacts and putting a bit of structure to that whole process. So that's been working well. So currently I maybe run this course once or twice a month, so that might just be advertised and people sign up to it, or it may be a department, you know, from somewhere in the UK saying, can we have this course for 12 or 14 of our nursing team, and I run it just as a bespoke course in that regard. So that's, you know, been a good steady piece of work and plenty of uptake with that. Other things I'm doing at the moment, so I still do occasional tutorials for optometrists and their staff, again in that whole sort of acute eye care area, and selling the resource pack, selling the booklets, and these are mainly being sold into the optometry sort of world. I still get asked to do occasional lectures or tutorials for different optometry groups and so on, and that's good. I suppose just engagement and, you know, promotion for Optometry Evolution. So just really trying to sort of grow this output. Next steps, again, just the ophthalmic nurses course is still really about 9 months into its running, so it's getting to the point where it's consistently 1 or 2 courses a month. So, you know, it's just a case of keeping that going, trying to grow it a little bit, and, you know, trying to put this out there as widely as possible. I've had interest from Taya Pharmaceuticals, who do a lot of eye care products, and they like the website from an optometry point of view, and we're working together to maybe develop what we call an IP optometry hub on the website. So IP is really independent prescribing optometry, so a section of the profession who have sort of full prescribing rights. So they've got a lot of CPD requirements, always looking for access to good quality educational content. So the idea of this hub is really to pull a lot of that resource together and try to become the sort of go-to area for that. And just to continue to work with Digital Health Sense in sort of building the market reach, both of the ophthalmic nurses course and this more recent sort of progression of the IP hub. So certainly busy between this and the hospital role, but you know, it's been a really interesting project over the past few years, just developing it and seeing how it sort of evolves as a resource. Okay, so a bit of a flyby tour, but hopefully that's been useful.
Fabulous. Thank you very much, Stanley, and thank you for including Digital Health Sense at the end with our logo too. That's very kind of you. I hope everybody will agree that across those 4 organisations, we've seen some very different approaches, some different technologies, some digital, some physical, some face-to-face, very varied. And I think that's given a good feel for the sorts of things that SMEs are doing in the area. So now we come to the crescendo, because it's over to Helen to talk about the centre itself and what's happening, where it's at, I hope, and when we're likely to see it open. So Helen, over to you.
Thank you. So my name is Helen Robertson. I'm absolutely passionate about people and service development, and my role is currently as the National Treatment Centre Manager for NHS Highland. We're constructing both an amazing building on the Inverness campus, and we're also constructing an amazing team to work within the National Treatment Centre in Highland. So it's a hugely exciting time for us. We're lucky in that we've had huge engagement throughout the process when we've moved from very much a thought process about having a national treatment centre to being in a position where we're delivering our national treatment centre in a proper sense. And our team vision is really moving forwards and delivering the best quality, state-of-the-art, innovative ophthalmology and orthopaedic healthcare to the people for the north of Scotland. Our strapline is our people, our planet and our pound. This project's actually been around since about 2014, so you can see it takes a very long time from inception to actually design to producing a building, and we wouldn't be here without the involvement of many, many people. 2014 we started initial conversations with the Scottish Government, and then we go through a sort of initial agreement, a full business case aspect. And we had huge engagement back in 2017 and 18 with 3P events. These were wide stakeholder involvement events, including our architect at the time, and the whole stakeholders involved at that time really came up with how we wanted the building to look. So the building that we're actually seeing now is a building that has very much been designed with the clinical team involvement. So it really is purpose built for both ophthalmology and orthopaedics. Our construction work started in 2020 and is due to be completed later on this year. Now, we are one of a national network of centres. The first centre opened in the Golden Jubilee with their eye care centre. They're currently expanding into producing another orthopaedic centre within the Golden Jubilee. Forth Valley is an orthopaedic centre that's currently under construction. NHS Fife and NHS Highland will be one of the first to come on stream. And then we're building centres in Grampian, in Perth, in Lothian, Ayrshire and Arran. So you can see it's actually a massive programme that we're involved in. So what are we going to be delivering within the National Treatment Centre in Inverness? So the centre, as I say, is a purpose-built facility. It's providing uncomplicated hip and knee replacement surgery. And those are for patients who are low anaesthetic risk, because we're an off-site aspect away from Raigmore. We'll be delivering foot and ankle surgery, hand surgery, and a full range of ophthalmic care, including outpatient and inpatient activity. The facility will have 24 beds, and 3 of those are flexible use for ophthalmic patients. We'll have 5 operating theatres, 13 consulting rooms, including 2 teach and treat and 4 virtual consulting rooms, a full range of ophthalmic diagnostic and treatment services, and a patient and staff cafe. I think that was one thing that people were absolutely adamant that we had to have on site, is good coffee. And as I said, we'll be part of a national network of treatment centres across NHS Scotland. And really that's becoming much more important because of our COVID backlog in terms of ophthalmic and orthopaedic cases needing treatment. Nationally, there was some discussion about how we needed to have a people plan in each of the national treatment centres, and we didn't want to have a top-down approach to devising a people plan. What we encouraged each area to undertake was a sort of bottom-up approach using an appreciative inquiry approach. So since 2020, we have been engaging with staff with a consultant working with us, really talking to staff on a one-to-one basis and asking about their hopes, their fears, their aspirations for the building. And what came out of that was a real focus on the need to think about quality, innovation, excellence, really best outcome for patients, and teamwork. Staff have said that they want to do things differently within the National Treatment Centre, that they want the opportunity to really learn, to develop, to undertake research and audit, and to focus on patient care and improve outcomes. And we recognise from the research base that if we have happy staff, we have happy patients, and that's really critical to the ethos that we want to have within the National Treatment Centre. The approach we've taken is to undergo a detailed workforce planning approach, thinking about our marketing and recruitment, our induction and our onboarding. And we have a huge marketing campaign that we're undertaking at the moment, and really live recruitment. For our building, we require an additional 210 full-time equivalent staff to work with us. We're also developing a target operating model, which is how the business will actually be conducted within the building. And that will move into a sort of operational readiness development as we move closer to our opening phase. And there's a huge amount of work that needs to be undertaken with a new building of this type. So we're thinking about our transition planning, our transition and mobilisation. So once our building is handed over to us, we then have to equip the building. We then have to scenario test, educate and train prior to our actual opening date and our first patients being treated. So the construction forms a small part of what we need to do, and it is a very busy landscape. This is a very short whistle-stop tour. It's maybe shorter than the 10 minutes. Our website is now live, and I'd really encourage you to take a look on our website. It's ntchighland.org.uk, and we have lovely videos of our staff on there. Our staff are our real advocates for our recruitment. And as we sort of develop our website, we're going to add specific patient information on there. So it's very much a live and developing arena. We have a strapline, Aim High, Aim Highland, which is our recruitment campaign that was started initially for the National Treatment Centre, but that's actually become the NHS Highland recruitment strapline. And that's really starting to bring lots of different people to the Highlands. We're getting lots of interest from other people wanting to come and join us on our journey, and just a hugely exciting opportunity for us. Thank you.
Thanks very much, Helen. That's a great way to end the presentation parts of what we're up to. So just a word to anybody that's still here in the attendees, you can still put questions in the session. But I'm going to suggest that all of the other participants that have pitched today, if they want to ask specific questions, please do shout. And if you've got anything specific you want to ask Helen, I'm sure she'd be happy to answer, but I'm going to go first. I'm going to use chairman's privilege and go first. So Helen, you talked about the 210 full-time equivalents that the centre needs, and I assume the target operating model is dependent on recruiting those staff, and we've all seen across the NHS the challenges about recruitment and retention of staff at the moment. Is that something that you're facing, or is there something unique, do you think, about where you are, because it's a wonderful part of the world, that makes it different and easier to recruit the people that you need to hit that target operating model?
I think we will share the same challenges as everybody else at the moment, and it is quite a different landscape post-COVID, and that we know a lot of nurses have actually retired from the profession. What we're doing is really trying to do things very differently, which is where our recruitment campaign has come from, and that's been an evolving process. We attended a recruitment fair, for example, and just to see how other people recruit, that was quite an eye-opener for us, and a real recognition that we had to do things quite differently. People recognise that the Highlands are a beautiful place to work. However, they don't recognise that actually we have huge career opportunities, and that it's more about than just a nice place to be based. People want to hear that we have career opportunities and career development opportunities. So I think historically as a workforce, we've always worked in silos professionally. I can say that because I'm a physio by background, and I think we need to challenge our existing paradigms. So thinking about how we make our workforce more resilient, how people work to the top of their license and the top of their ability, and think about slightly different roles within that workplace arena, and also thinking about our pipeline into healthcare. So we're actually working with the NHS Scotland Academy, Skills Development Scotland, to do something with a youth academy type approach in NHS Highlands. So we've got a test pilot. Unfortunately, it's going to be a bit late for us, but that will come on stream next year and hopefully help to bring people in from that sort of youth entry and develop that whole career pathway for them.
Okay, thank you for that. Now I'm going to ask one more, which might actually lead to Sachin, Leaf and Hakan following up maybe. So at the top of your list of where you're going to focus, you talked about uncomplicated surgery as being a focus area. And we've just heard from a couple of organisations talking about things that sit between invasive and non-invasive approaches. So do you see the sorts of things that they've talked about as being part of what you're trying to cover in your remit?
I think, well, ultimately the National Treatment Centre will deliver that surgical element. So what can, what only can surgery do? But I think we have to think about the orthopaedic approach in its entirety. So it's really important. And again, that comes back to those silos. So it's thinking about what can we do differently. We know that we have a very aging population. How do we actually manage people's expectations, and how do we manage our resources, which are scarce across that whole arena?
Okay, don't be shy, guys. If you want to follow up on any of that, please do. Otherwise, I'm going to start asking questions of you.
Helen, just one question for me really quickly is, I fully appreciate it's integrating that end-to-end pathway, and the National Treatment Centre, whilst it's absolutely, yes, focused on surgery, what of the pathway redesign before they get to the treatment centre? Has that been part of the plans in terms of kind of reorganising that clinical pathway so there's a seamless transition of care from primary to secondary, and then introduction of innovation into that?
Absolutely. So we've been looking at the whole pathway for orthopaedics, thinking about pre-referral, but more importantly from that pre-assessment point. So from the point of listing, how we actually stratify our waiting list. So thinking about complexity, thinking about anaesthetic status, and really, as I say, for the treatment centre, it's that ASA 1 and 2 cohort that will have their treatment within the treatment centre. But thinking widely, what can we do within theatres to be more efficient? How do we maximise our workforce roles? So there's been a huge amount of redesign and transformation ongoing. That's not just within orthopaedics. Dan on the call from ophthalmology. The same sort of detailed work is ongoing in ophthalmology as well.
Thank you.
Okay, thanks. Well, a quick follow-up session from me then. So going back to that question about the gap between invasive and non-invasive, which is where you've described you sit, do you see that, and maybe I see it a bit in NHS England, that people classify things as invasive or non-invasive, and so because you sit in that gap, it's sometimes hard for people to see where to put you or how to procure you even?
Yeah, it's a common question that we have. So there's two things, and having spoken to a number of knee surgeons and a clinician by background, I don't think I'm speaking out of turn when the feedback that I've had is, if it looks different, we don't understand it, and if it's not a knee brace or if it's not a knee replacement or prosthesis, then sometimes it's something that sits in the too hard pile. So we're very careful to ensure that it's the right cohort of patients that get our treatment, and it is that point where we know that the core treatments, and actually as Hakan and Leif have already very well articulated, it's the right treatment at the right time for those patients. And actually there's a cohort of patients that benefit from digital solutions, but then there's a cohort that definitely don't benefit from Apos, where they haven't got the right care in community, so they've got to a point in their treatment or in their disease state where they do need some level of orthopaedic opinion, if not surgical intervention. And it's what can we do to avoid that? Because I think, Helen, as you mentioned already, if you're risk stratifying I think there's going to be a cohort of patients that aren't suitable for surgery anymore, or the surgeons don't want to treat because they're very high risk. And at that point, there is no alternative for them, which is where we come in. So I think with Apos, it's hard to know sometimes whether we sit in the provider side or whether we sit in the community side. In fact, it's both really, because there are patients that should be receiving that treatment in community, but also at the provider end, we need to be able to refer those patients in so they are getting some effective treatment, when previously, up until now, there hasn't been an alternative for them.
Okay, thanks. And Leif and Hakan, are you seeing the same sort of thing with a digital solution that clinicians often aren't quite sure where it fits?
Partly, but I don't see it exactly always as a gap, because I think it's a lot of having a process for the patients from some kind of a start to the end, and that OA is very changeable over time. So sometimes orthopedic surgeons see patients without pain, but they were painful when they were referred, and there will be nothing done. Or they are in a lot of pain, but they haven't tried any other treatment that is with less risk and also more cost effective. So I think the easy solution for the gap is to have the patient going through a triage and then being referred when first-line treatment doesn't work very well. I think that would ease up things and make surgery much more effective, and surgeons only seeing patients that are more likely to benefit from surgery.
Yeah, because for those of us in the general population, there's some scary statistics in some of what you both covered. So you talked about major complications in 5% of the cases. So that to me says there's probably minor complications in a great deal more. And you also talked about 20% of treatments causing harm. And that's quite a scary thought, that we're heading, if we're not looking carefully at the pathway, that we're potentially causing lots of risk and harm in here. I guess you do have the benefit that you can use the app word. And of course, in the world in which we live now, app frenzy is one of the positives and negatives. It's a double-edged sword. Must have an app for everything. And maybe I can throw over to you, Stanley. The fact, you've described an evolution of what you've done from paper-based to online to. Do you see this perhaps through the partnership that you described at the end? Do you see this heading into the other app-type solutions, or is that not the direction of travel? Decision support, if you like. For the
the whole triage element probably does lend itself to an app, particularly within the sort of optometry practice setting. If it could be integrated into you know, the sort of practice software. So, you know, they open up a triage screen and they put in the details and so on, and then that maybe feeds through to the optometrist. So I think there probably is something in that. Saying that, from a personal point of view, in terms of actually delivering, I know it's, you know, like this, it's on, you know, virtually, but it's still face to face to some extent. And actually just having that sort of level of interaction with people, you can see directly if they follow what you're chatting about or whether there's any confusion, or you can iron out any areas that they don't understand. And from sort of an educational point of view, I still, you know, quite enjoy that, rather than, you know, somebody just logging on to quite a sterile, you know, sort of system. But I think there probably is scope, you know, longer term for that, particularly if demand for the ophthalmic nurses course grows and I can't physically kind of deliver that to everybody. Maybe that comes into a sort of an online sort of offering. But again, it's the time and everything else, the resource to build that and to develop it. So yeah.
Yeah, and I think that's for all of the companies here. The issue is always about how do you scale, and you know, all of you have talked about examples. So Sachin, you gave the Essex example with the cost savings and the numbers. You talked about the clinical trials, and Leaf and Harkin, you did the same and talked about Nottingham. I think was it Nottingham, the university that you'd worked with, as one of the examples. And we often are in this world where we see something that makes a huge impact in a local health economy, but we can't find the way to support people to scale that. And there are lots of cultural things that stop that happening. Sometimes there are just resource constraints. So Stanley, a lot of yours is that it's you that's doing still much of it. So how do you get a team around you to make that happen? How do you franchise what you're doing? Even when you're quite an established company, as both Apos and Joint Academy are, it's still hard to take advantage of the successes that you had and get people to replicate what you've done. So Helen, don't be surprised when each of them come to you and ask how they repeat. I'll be disappointed if they don't come to you and ask how can we work with you. That would be very disappointing. And I'm going to ask just one little question. It's about branding here. So when I look at the screen here, so on the left, I can see Stanley in my bottom left-hand corner, and I can tell what he does because his company is entitled Optometry Evolution. Yep, I know what that's about. When I look at Leaf and Harkin, Joint Academy, does that tell me what you do? I don't think it does. And maybe even to in between the two, Apos too. So, you know, sometimes maybe the constraint on this is people understanding very quickly what it is. Again, they're not here, but retina risk says on the tin, I think, what they're trying to do. Do you think that's a factor in your growth and evolution, or is it a red herring that I've pulled out of the can?
Can I comment briefly? I think we're so overloaded with information in the modern world, whether it's on social media, TV, working life, everything else. I think in some respects, for something to stick a little bit, you know, somebody probably has to see or hear a name of something or a brand before it even has a chance of kind of sticking. So I suppose, plain and simple, you know, possibly has to be the case, and require minimum thought, you know, as to what this is about.
Yeah, I think it's not a red herring, Adrian and Stanley. You're right. I think you need to be able to hear a name and know what it's about. I mean, Apos actually stands for All Points of Stance, so it's an acronym, but not many people know that. So it is a barrier for us to ensure as many people know about us as possible. Yeah, I accept that. I think one of our challenges is just understanding whether devices. Is it a shoe? Is it are they pods that go on the bottom, or is it the whole thing? Do you get a pair? So I think that's just kind of understanding just the mechanics of it, I think is sometimes a challenge for us.
I don't know if I can give a short comment as well, but it was not very easy to find a good name. There were a lot of trademarks and already names taken that we thought maybe would have been better. So we would like to show that we are academics and that we are dealing with the joints. So that was the reason. However, when we started in US, there was a lot of laughs about what kind of joints we were having or dealing with. But now lately, the last couple of years, we heard nothing about that.
So that's really interesting to hear that, because obviously I was aware of you. I've been aware of you for a while, and I've crawled all over your website, and I hadn't used the word joint as you've just used it. I'd used it in the, it's two things working together in harmony, which just goes to show why brand is important. So in a minute, I'm just going to ask Claire if there are any other questions floating about that I should pick up on. But before I do that, Helen, I rather bluntly said, don't be surprised when these guys contact you. I assume you're not going to say, please don't contact me, that you're quite happy to be contacted after this event.
Yes, please contact me.
There you go, chaps. So Claire, is there anything that I can pick up from anybody else that's put anything in the chat, or shall I draw it to a close just a couple of minutes early?
Yeah, we've had a couple of questions through. Thanks so much. So this one is for Sachin. The Apos biomechanic footwear looks amazing. What is the price for a pair of shoes? And can the shoes be reused, repurposed for another patient, or are they one-time use only? Thank you.
So the cost of the device is cost neutral to compare to a brace. It's a pair of devices. So a brace is around about £600, I think, for a rigid brace, depending on where you look and depending on what the volume discount is. So we are cost neutral to a brace. A patient will have a pair of devices, and they use that for the lifetime of their treatment. So some of our patients have had it for 8, 9, 10 years, and they dip in and out of treatment. So it's for the patient. The only thing we would tend to replace if they wear out are the pods underneath the device, but that's based on usage, and patients only wear it for an hour a day indoors, so we tend not to get a lot of wear and tear on them.
Thank you.
Okay, great, thank you. And the next one, I think we've got time for one more. So our last question is for Joint Academy. My perception is that there are lots of free apps that target joint and back pain improvement. What is the USP for Joint Academy? Is it the access to physical therapist or something else?
Would you want to take this, Leif, or does Rio want to answer?
Yeah, I can bring, oh yeah, there's Rio.
I'm in. I've been lurking in the background. I take care of the operational and some of the clinical side of things for Joint Academy in the UK. And I think what makes us unique is not only the fact that we're able to offer convenient treatment to patients anywhere at any time, but also that we have several touch points with patients. And that differs from a conventional face-to-face model, particularly when you look at the waiting lists at the moment. So our physios will have sometimes daily contact in the form of messaging, mostly calls, comments, and then the patients also receive these exercises every day. And aside from that, we have a team specifically dedicated to looking at how patients interact and engage with the app and how we can build maximum compliance with their exercise programs through that. So Leif and Helen look at statistically and in terms of best practice what patients most likely to benefit from. And then our product architects look at how patients will actually use that within the app. And that together with those regular touch points really builds patient compliance. And I think it's something that makes us very special.
Yeah.
Great, thanks, Rio. I think that's us for questions, Adrian.
Okay, well then, thank you very much, all of the panelists, and I'll hand back to Andrea, I think.
Yes, thank you, Adrian. I hope you can hear me okay. I just wanted to thank you all for taking time out of your busy days to join us, because I know you all have a lot to do, running businesses, making sure the National Treatment Centre is getting off the ground as planned, recruiting loads of staff. So thank you very much for your time today. It's been great to get an insight from you on all the different aspects that you're working in on and the solutions you provide for patients. I just wanted to finish off by actually drawing your attention, or the audience attention, I guess, to a couple of events that we have upcoming. And it's 2 further webinars before or just after the summer break. And we have one webinar that is, oh, I think you can't actually see my slide anymore. Sorry for that. The first webinar is Frontier Science. They are a clinical research company based in Kincraig, just south of Inverness. So if you have time to join us, the webinar will be on the 22nd of June. And the other webinar that we haven't quite decided when we're going to host it, either before or after the summer holidays, is Health Products for Purchase by Consumers. And that's another business to healthcare webinar. To book, please just have a look at our websites, hi.co.uk/events, and you should also see social media coming through as well, advertising those webinars. So if that's of interest to you, please join us for those. But yeah, just to thank you again for taking time out today, joining our webinar, and for Adrian as well, hosting an amazing session. You always have a really good way of drawing out the interesting questions and the great answers from our participants. So thank you very much and have a good rest of the day.
That's great. Thanks, Andrea. On behalf of Highlands and Islands, thank you to everyone that came in to join the webinar. Our post-event survey will pop up straight after this session. So if you can spare a couple of minutes, it would be great if you could complete that for us. Thank you very much for your time and have a great day.